Well, hello, my name is Dr. Dan Lozier, and today we're going to be discussing the management of patients that have GI disorders. So let's get started. Now, even though I usually don't have statistics on my tests, I think the statistics here are very important for you to recognize. It's important to know that even though your patient may come into the hospital for a different admitting diagnosis, they may have an underlying GI disorder that you need to be aware of and you need to monitor for. You can see the vast number of millions of patients that have GI disorders, billions of dollars in medical expenses. But what I think is really important for you to look at here is this statistic. 240,000 patients die every year from GI disorders. That's an extremely large number. So we need to be aware. We need to be the ones that have the eyes and the ears on our patients 24 hours a day to monitor for complications, because patients can die from diverticulitis. Patients can die from GI hemorrhage. Patient can die from uncontrolled ulcerative colitis, bowel obstructions, etc. So we need to be on our A game and recognize what are the clinical manifestations when these GI disorders flare up. Now, you would think with this number of patients that have GI disorders that there's probably a lot of genetic involvement, etc. No, let's look at what it is on the bottom here. The major contributing factors: fast-paced lifestyle, high stress levels, insufficient intake of fiber and water, lack of daily exercise. Kind of sounds like nursing students, doesn't it? Yeah, so in our Western society here, we've got a long way to go. And that's why I'm always proselytizing that we in the healthcare community need to be about creating healthier communities. We need to have healthier populations and not just be focused on our advances in diagnosis and treatment. One of the things you're going to quickly find out about me is that I am enamored with the human body. I think it's miraculous. I think it's also very important for you to recognize as future healthcare providers the anatomical structures of every system in the body and their correlating physiologic functions. If you don't understand the anatomy and physiology of a system, it's not going to make sense when we start talking about clinical manifestations of our patient, when we start talking about pharmacologic interventions, medical interventions, surgical interventions. I always like to start my lectures talking about the anatomy and physiology. I know you've had A&P before. This hopefully will be just a review for you. So when we're looking at the anatomy of the GI system and the physiologic function, there's three primary roles of the GI system. One is digestion. What is digestion? It's the breakdown of the foods that we ingest into their molecular level. Absorption is the second. Absorption is when the small intestine and the large intestine absorb those nutrients. Eventually, they make their way to the vasculature so that we can provide nutrition to the entire body. And the third is elimination. Now, we're not talking about excretion, we're talking about elimination, and that's the process whereby we eliminate our waste products from the body. So let's look a little bit about how this happens in the GI system. First, we're going to ingest our foods. When we ingest our foods, we will chew them in the mouth. That's called mastication. It will mix with saliva and other enzymes, and then we will eventually swallow with the swallow reflex. That food is then going to pass into the esophagus being a hollow tube of about 6 inches in length. And it is also has smooth muscle. The smooth muscle inside of the esophagus is going to cause a peristaltic movement of that food downwards. And then if you look, let's see, let's look right in this area right in here. So in this area right here, at the lower end of the esophagus, we've had what's called the lower esophageal sphincter. The lower esophageal sphincter is made up of smooth muscles that relax and allow the passage of food from the esophagus into the stomach. Once the food reaches into the stomach, then it also will mix with other enzymes. The stomach itself is lined with a thick mucosal layer, so you'll have a lot of mucus secretion. But the other thing that is important is that the stomach is going to manufacture and secrete hydrochloric acid. Hydrochloric acid is very important. It kills a lot of the bacteria that's in our food, and it helps to break down solid foods. So the stomach will churn the food back and forth. It'll mix with the enzymes, with the mucus, with the hydrochloric acid. Eventually it become to a mushy type of substance that we'll call chyme. It will then pass through the pyloric sphincter, and now it's into the most proximal section of the small intestine, and we call that the duodenum. Now, we're still in the digestion phase. We're still in the breakdown of the food to the molecular level. So what happens in the small intestine is that this organ right here, the pancreas, is going to manufacture bile. That bile is going to travel down these ducts to the gallbladder. The gallbladder is just a storage reservoir, and at a certain point of time when food moves into the duodenum, the gallbladder is going to release that bile. That bile released into the duodenum is going to continue to help with the breakdown, particularly of fats. Now also superimposed back here behind the stomach, we're going to have the pancreas. The pancreas is most well known for its secretion of insulin, but also it plays a key role in the digestion process. The pancreas is going to secrete amylase, lipase, and trypsin, which are going to further break down the foods relative to carbohydrates, proteins, and fats. Now remember that we said that the stomach has hydrochloric acid. Actually, the pH in the stomach can be as low as 1, very acidic, but these buffer mucosal walls is going to prevent that hydrochloric acid from eating away the wall of the stomach. But the duodenum, the ileum, the jejunum, they do not have mucosal linings. So that hydrochloric acid, that very low pH, is going to eat away or erode the small intestine. Well, guess what? In its miraculous fashion, the body's going to compensate for that. The amylase, lipase, and trypsin that is secreted from the pancreas is also very heavily laden with bicarbonate, and that bicarbonate is going to buffer the acid. So then the food is going to move from the duodenum and it's going to go into the longest section of the small intestine, back and forth, and that is the jejunum and the ileum. And that's where the majority of the absorption of the molecules is going to happen. Once it passes through the small intestine, then it's going to come to this juncture right here. And this juncture is at the separation between the distal ileum and the cecum, which is the most proximal section of the large intestine. Peristaltic movement back and forth, and downward is going to move the food across this valve, the ileocecal valve. And now the food is really becoming more waste product and fecal matter. Most of the nutrients have been absorbed. However, the large intestine is responsible for the primary absorption of water and electrolytes. So peristalsis is going to move food over into the cecum. This little finger-like appendage down here, the appendix, is going to fill with the fecal matter along with the cecum, and then peristalsis is going to move that fecal matter up the ascending colon, across the transverse colon, and down the descending colon. Now, the most distal section of the large intestine is called the sigmoid, or the sigmoid colon, and more to come on that. Now we're talking about fecal matter that is very well formed. A lot of the water and absorption and electrolytes has happened early on here. So that formed fecal matter is then going to go to the rectum, which is a reservoir for the fecal matter. When the fecal matter causes enough pressure in the rectum, then the patient is going to recognize that pressure and is going to relax the anal sphincter. And at that point, we will have elimination of the waste products or the stool. Fascinating, absolutely fascinating. This particular slide and the next slide is just another pictorial representation of what I discussed in the previous slide. So it's good for your review. And likewise, excuse me, this slide here gets into a little more specifics about where within the small intestines and the large intestines the proteins, carbohydrates, fats, water, electrolytes are absorbed. This is an interesting piece right here. When you look at fat malabsorption that happens in the ileum. In the event that you have a patient, for example, that has Crohn's disease and they have a significant area within the ileum that is diseased, and that area is inflamed, it might be scarred, it's no longer participating in absorption of fats. What's going to happen is those fats are eventually going to continue to make their way through the small intestine. They're going to get into the large intestine, and eventually they're going to be eliminated as part of the fecal matter. So when you see a patient that is having fat malabsorption, you may see manifested in their stool fatty, greasy stools, and that is called steatorrhea. Likewise, this is an interesting piece right here that vitamin B12 is also absorbed in the ileum. Well, what we now know is that in order for B12 to be absorbed into the body, it needs to combine with something called intrinsic factor. Intrinsic factor is actually manufactured in the stomach and secreted in the stomach. Then it will find its way into the small intestine where it will bind with vitamin B12. What happens if vitamin B12 isn't absorbed? Well, what happens is that we have anemia. Vitamin B12 is required for the synthesis of red blood cells. So in the absence of vitamin B12, then we have what's called pernicious anemia. Fascinating. Well, congratulations to all of you. You successfully passed health assessment in 102. So don't forget that assessment data that you learned in that particular procedure and process for assessing a patient's GI. What are some of the things that are important in GI? Well, first of all, let's start with chewing and swallowing. That is very important for the digestion piece. We're going to look at the patient's abdomen. We're going to palpate it. Is it firm? Is it hard? Is it distended? Is it soft? We're going to listen to the bowel sounds, and not just listening to the bowel sounds to see that they're present and then move on. What you're going to do is you're going to listen to the bowel sounds, be able to assess, are they normal, what we call normoactive? Are they hyperactive? Are they hypoactive? Are they distant? Are they absent completely? Is there any tinkling, any high-pitched gurgles, rushes, etc.? So take your time in assessing the bowel sounds. They're very important to you. So that, in addition to the other assessment skills that you learned with the GI system, you're going to employ. So if you have to review those, go ahead and do so. And these are the specific diagnostic studies that we will be talking about when we talk about the disorders. For example, we might talk about CBC. Why is that important? Well, CBC is red blood cells, white blood cells, hemoglobin, hematocrit. So a patient that has an infection is going to see potentially an increase in your white blood cells, an elevation there. Patients that have GI bleeds, pernicious anemia, we're going to see a decrease in the red blood cells. We may see that also causing hemoconcentration, or we'll have an alteration in the hemoglobin and the hematocrit of our patient. Patients that have pancreatitis, we're going to see an elevation in the amylase and lipase. CEA, carcinoembryonic antigen, is a biomarker for a patient that has colorectal cancer. Let's look at stool studies. We'll talk about those in lab in upcoming weeks. If we have the presence or the suspicion that a patient has a GI bleed, but it is not visible in the patient's stool, we may do what's called a fecal occult blood test. You probably recognize it as a hemoccult. Occult means it's invisible, it's not visible. The blood could be there, but we don't see bright red blood in the stool. So we'll do that test in order to determine whether indeed there is blood in the stool. We're going to spend some time in upcoming slides talking about endoscopic exams. Endoscopic exams such as EGD and ERCP, which is for upper GI. Sigmoidoscopy, colonoscopy is going to be more for lower GI. And then with imaging, CAT scans, PET scans, MRIs. But we still go to the old faithful, which is for upper GI analysis of problems, the barium swallow, and lower GI, we're going to look at barium enemas, which are still very prevalently ordered on our patients in the hospital today. All right, in this slide, you're seeing some of the pharmacologic agents that we might employ on our patients with GI disorders. For testing purposes, I will let you know more specifically the medications I want you to focus on as we talk about those particular GI disorders. I do want to spend a few minutes here looking at a couple of these. One is the H2 receptor antagonist. H in the H2 stands for histamine. A major contributor to GI problems is an abnormal secretion of hydrochloric acid, or when hydrochloric acid is where it shouldn't be in high concentrations and high acidity, such as in the esophagus with GERD, or maybe in the stomach when the mucus lining breaks down, perhaps in the duodenum where we might have peptic ulcer issues. So we are going to be giving medications that is going to block hydrochloric acid secretion, hydrochloric acid levels in the GI system. The two that we're looking at, the first is H2 receptor antagonist. The histamine receptor antagonist. So that's what the H stands for right here. It stands for histamine. So what are the medications that are going to inhibit hydrochloric acid secretion? Histamine, let's look at cimetidine. Histamine, cimetidine, famotidine, histamine, ranitidine, histamine. So just think when you see the ene, ranitidine, famotidine, cimetidine, think of histamine. And likewise, another type of medication classification are proton pump inhibitors. They both are going to do the same thing. They're going to decrease the amount of hydrochloric acid. How will you remember what's a proton pump inhibitor? Just think proton pump, proton, esomeprazole, proton, omeprazole, proton, pantoprazole, proton. All right, so hopefully that will help you to remember. Remember histamine, cimetidine, ranitidine, famotidine. All right, good deal. Where the previous slide talked about upper GI disorder, pharmacologic agents, this one is going to be talking about lower GI disorders. No, you do not have to know all of these laxatives. But what I want you to recognize is that, we talk about giving a patient a laxative. They all have the same hopeful effect, which is to facilitate passage of stool from our patients, but they're not all alike. Look at all the different pharmacologic actions. This one happens to be bulk forming. This one stimulates peristalsis. This one softens your stool. This one draws water into the stool to hopefully soften it. So when you say giving my patient a laxative, it's important to recognize they don't all work the same, and the different laxatives are ordered by the physicians for different reasons depending upon the patient's situation and condition. Aminosalicylates we will talk about when we talk about inflammatory bowel disease. Corticosteroids, just know that corticosteroids are powerful anti-inflammatory agents. So they're going to block or inhibit the inflammatory response. Prednisone is the oral form, and then we have hydrocortisone, Solumedrol, Solu-Cortef, which is the IV form. And we'll talk about those specific to the GI disorders. Immunomodulators like infliximab is a really big one. You're probably seeing commercials on TV for that one. They also have to do with inflammatory bowel disorder, and we'll talk about them in specifics when we get to that section of the slide presentation. Okay, now let's get to the good stuff. We'll start talking about the GI disorders, and we'll divide those GI disorders up into upper GI disorders and lower GI disorders. Let's get going. The first GI disorder that we're going to talk about is achalasia. Achalasia involves the esophagus. Remember when we said that there was the lower esophageal sphincter, an accumulation of smooth muscle whose responsibility it was to relax, to allow the food to pass from the esophagus into the stomach? Well, sometimes that lower esophageal sphincter doesn't work. We call that an incompetent lower esophageal sphincter. In that situation, even though there's the presence of food and an increase in pressure in the esophagus, that smooth muscle doesn't relax. So what that causes is it causes the food and the liquids and the gases to accumulate in the esophagus. They're swallowing, they want it to pass the esophagus into the stomach, but it literally gets stuck in the esophagus. You can just imagine how uncomfortable that is. I have a close friend who suffers from achalasia, and I've been present with him on a couple of occasions when it has flared up on him, and it looks miserable. So achalasia has to do with the incompetent lower esophageal sphincter, trapping of food. So the clinical manifestations make sense on the patient, where they have difficulty swallowing. They also will experience, as that pressure builds up in the esophagus, they're going to experience pyrosis, otherwise known as heartburn. So how would we diagnose a patient that has achalasia? We're going to look at a diagnostic study that is going to look at the upper GI. Upper GI is going to be your mouth, your esophagus, your stomach, and probably maybe down getting into the duodenum. A little bit. So clinical manifestations make sense. If the patient has the food and the fluids that are stuck in the esophagus, they're going to have difficulty swallowing. All right, difficulty swallowing, that pyrosis. But what we're going to see on diagnostic studies, let's look at endoscopic exams. An endoscopic exam that we mentioned earlier is an EGD. EGD stands for esophagogastroduodenoscopy. So esophagogastroduodenoscopy, that's why we say EGD, is going to look at and be able to visualize the anatomical structures and physiologic function of the esophagus, the stomach, and the duodenum. If we're looking at the ducts that we talk about, the common bile duct, the hepatic duct, the pancreatic duct, that's when we're going to use the ERCP, endoscopic retrograde cholangiopancreatography or something of that nature. Again, that's why we call it ERCP. We are going to use the barium swallow. So the barium swallow is going to be able to, in real time with video, be able to look at how the patient swallowing reflex is working, passage of food from the esophagus into the stomach, etc. These are not so much important in manometry, but I did mention that there will be a buildup of pressure in the esophagus when in the presence of food that should pass as soon as the food passes from the esophagus to the stomach. But how are we going to manage this achalasia? Well, we said that the primary concern is that the smooth muscles aren't going to relax in the lower esophageal sphincter, causing trapping of food in the esophagus. So we're going to give medications that are going to relax those smooth muscles. Calcium channel blockers would relax muscle. Nifedipine is an example. You'll see that a lot of times calcium channel blockers are going to end in PINE, amlodipine, nifedipine. Nitrates. Isorbide dinitrate is the example that would be good for you to remember. Um, Also are going to be muscle relaxants. Interestingly enough, when we get to cardiac down the road, we're going to see that we give calcium channel blockers to patients with cardiovascular problems such as hypertension. We give isorbide dinitrate, nitrates to patients that might be experiencing angina. And so we relax the smooth muscles, which is going to decrease our blood pressure, and it's going to dilate our arterioles and hopefully allow more oxygen to get to the heart muscle itself, so that we don't have that anginal pain. More to come on that. This slide is just specifically talking about those medications that we mentioned in the previous slide. So just additional reinforcement and review for you. GERD, gastroesophageal reflux disease. We'll see that on a lot of our patients. GERD is the excess reflux of gastric acid from the stomach into the esophagus. It's interesting to note that we all, to some degree, experience GERD. The problem is that those experience it excessively or repeatedly. We mentioned that the stomach has hydrochloric acid in there. That hydrochloric acid can have a pH as low as 1. That is okay in the stomach, remember, because the stomach is lined with a thick mucosal lining, secreting mucus, and that's going to buffer the stomach wall from that hydrochloric acid. Well, when that hydrochloric acid refluxes up into the esophagus doesn't have that thick mucosal lining. And exposure to that hydrochloric acid in the esophagus is going to cause burning sensation, a very, very unpleasant sensation. And continued exposure of the hydrochloric acid to the esophagus is eventually going to cause an erosion of the wall of the esophagus. It's going to cause ulcerations. And we actually call those peptic ulcers. They can occur other places, and we'll talk about that shortly. So the symptoms, the clinical manifestations certainly make sense that we're going to have pyrosis, which is a burning in the esophagus, indigestion, difficulty in swallowing. Those are the kind of the primary ones. But just the burning and the feeling of indigestion is the most common clinical manifestations. So here we go again. If we want to use an endoscopic exam to visualize the esophagus and the stomach to see if there is reflux of gastric contents, which are the endoscopic exams that we're going to use? Yes, the EGD, which visualizes the esophagus, the stomach, and the duodenum. No, we're not going to use the ERCP because those visualize the ducts, hepatic duct, pancreatic duct, common bile duct, etc. Here's that barium swallow again, which is still very, very much utilized. And don't have to really recognize or understand too much the wireless pH monitoring at this point. Well, now what do we have here? Hiatal hernia. I just remember my mom always talking about people that have hiatal hernias, and I really didn't understand what that was. And let's talk a little bit about what exactly a hiatal hernia is. First of all, a little bit more review on anatomy. Think about where the esophagus is. Originally, when the esophagus is coming down, the esophagus is in the thoracic cavity, right? What it's showing right here is that this is the heart. So the esophagus is in the same cavity as the heart. So how in the world does the esophagus get from the chest cavity down into the abdominal cavity? Well, because remember that's separated by this diaphragm right here. Well, in the diaphragm, there is a slit. There's a slit in the diaphragm, and that is called the hiatus. That slit is just large enough to allow the esophagus to pass through from the thoracic cavity into the abdominal cavity. What happens in a hiatal hernia, if we look over on this slide, is that that hiatus expands. It enlarges. It doesn't hold the esophagus in place. And now, because the hiatus is enlarged, what it does is it allows the stomach and the esophagus to slide up and down. So they're sliding up and down. And at some point, the stomach is going to get pinched off by the diaphragm, and it's going to shoot the hydrochloric acid up into the esophagus. So again, and then we have GERD, and that's very painful. So hiatal hernia actually is one of the most common causes of GERD. So how are we going to manage a patient that has gastroesophageal reflux or GERD? I just want to let you know there are going to be questions related to diet and GI. So for a patient that has GERD, the recommendation is for a low-fat diet, but also the patient's going to avoid things that stimulate the release of hydrochloric acid, such as caffeine, beer, milk, tobacco, carbonated drinks, mint. Kind of sounds like avoiding life, doesn't it? We're also going to encourage our patient not to eat 2 or more hours prior to going to bed. And it makes sense if the patient is going to be laying flat. We're not going to have to work against gravity in order for the stomach contents to flow into the esophagus. So we recommend, because of that, that the patient not eat or drink 2 hours or more prior to going to bedtime, but also we recommend that they sleep with the head of the bed elevated, and that could be just a matter of propping up pillows for the patient. We're going to give pharmacologic agents, here we go, to decrease the amount of acid. So we might give famotidine, we might give ranitidine, famotidine, histamine, ranitidine, histamine. So those are examples of that H2 receptor antagonist we talked about. Omeprazole, pantoprazole, proton pump inhibitors. We just talked about those. I'm stressing them, so I bet they're important for you to be able to understand and apply. Prokinetic agent, the one that we're going to talk about is metoclopramide. Reglan, you might have seen it. What metoclopramide does is it accelerates the emptying time of the stomach. The longer that there is contents, food contents, hydrochloric acid in the stomach, the higher the potential risk that it's going to reflux into the esophagus. So if we speed up that gastric emptying time, normal emptying time is 30 minutes to an hour that the food is going to move from the stomach into the intestines. If we speed that up by giving a medication, we're going to decrease the amount of time that the hydrochloric acid has the potential to reflux into the esophagus. That medication is metoclopramide. What I want you to recognize, and it's hidden a little bit behind my mug, is that metoclopramide is contraindicated in patients that have Parkinson's disease. And that's because it affects the central nervous system. So I think that this is the only medication in the entire GI lecture that has a contraindication to it. So that might be an important caveat to remember, or something that might be potential testing material. Remember that is contraindicated, metoclopramide, in patients that have Parkinson's disease. There is a surgical procedure that helps to decrease GERD. That's called a Nissen fundoplication. And you thought that they only made cars, huh? So Nissen fundoplication, it's interesting. The problem is that there's reflex from the stomach up into the esophagus. So the way that they manage that is that they actually take the fundus of the stomach, which is a section of the stomach, and they pull it up, and then they wrap it around the lower esophageal sphincter here. they wrap it around, so they're constricting the lower esophageal sphincter and thereby decreasing the opportunity for the gastric acid to reflux. Gastritis, we probably have all experienced multiple times, very uncomfortable. Gastritis is an inflammation of that thick mucosal lining around the stomach. A lot of people seek medical attention for that. It causes, we've had a nausea and vomiting, and we're just feeling lethargic. Look at this, one of the interesting clinical manifestations for people that have gastritis is hiccuping. I like that. That would be a fun one to test you on. I think it's the only GI disorder that has hiccuping as a clinical manifestation. The two primary causes of that inflammation is H. pylori, which is a bacteria that we found that causes gastritis and peptic ulcers. And look at this one, NSAID abuse, non-steroidal anti-inflammatories, your Tylenols, your aspirins, your Advils, non-steroidal inflammatory agents, if they're overused or abused, in shutting down the inflammatory response, what they're also shutting down is the secretion of mucus from those mucus secreting glands in the stomach. Well, you decrease the mucus secretion in the stomach, and that allows the hydrochloric acid to bypass that buffer and actually cause irritation, inflammation, ulceration to the wall of the stomach. So if we're going to be visualizing with an endoscopic exam, we're going to be visualizing the stomach. What do you think we're going to use? Yes, we're going to use that EGD, esophagogastroduodenoscopy. Very good. We might even give medications that are going to block hydrochloric acid secretion. How about cimetidine, famotidine, ranitidine, proton pump inhibitors like omeprazole, esomeprazole. So I told you you were going to see a lot of those, and it is important for you to recognize H2 receptor antagonists, proton pump inhibitors. These are some examples of nursing diagnosis that you might see with a patient with gastritis. Probably might not be something I would initially test you on, but when we get to some of the more severe chronic disorders, I think that's when the nursing process and some of our nursing diagnoses may become a little more important for us to recognize. All right, peptic ulcer disease. Peptic ulcer disease results from when the hydrochloric acid gets to the lining of the anatomical structures of the GI system, eventually causes irritation, inflammation, ulceration, and possibly even perforation. Those areas that are exposed potentially to hydrochloric acid is the stomach. If there's something that inhibits that thick mucosal layer from secreting mucus, the hydrochloric acid can affect the lining of the stomach to the point where it could cause ulceration and perforation. Same way in the esophagus. When you have GERD and you have reflux of hydrochloric acid and stomach contents into the esophagus over prolonged exposure, that can cause inflammation, irritation, ulceration. The duodenum as well, when the hydrochloric acid and the stomach contents move into the duodenum. If there's no base buffer, they also, over a prolonged period of time, the duodenum can experience erosion and perforation of the wall of that particular anatomic structure. Now, the problem with peptic ulcers, if they go unchecked, is when that ulceration indeed does perforate, the stomach or perforate the duodenum. Now, what we have is non-sterile, bacteria-laden stomach and intestinal contents leaking out into the sterile peritoneal cavity. When the peritoneal cavity is exposed to the hydrochloric acid and the bacteria in the stomach contents. It causes an inflammation of the lining of the peritoneum. That's called peritonitis. That helps to facilitate the uptake of bacteria into the bloodstream. That's called bacteremia. It will then travel to the organs of the body, and you begin to see symptoms. That's called sepsis, and eventually what you have is or a multi-organ failure, and that is septic shock, and the patient is going to die from that if it is not reversed. Getting back to that original slide, remember 240,000 patients die every year from GI disorders. Do you think anyone has ever died from a peptic ulcer? Yeah, you better believe, sure, that they have. So we need to be able to recognize that even though our patient might be in for something else like a hip replacement, they have a history of peptic ulcers, they could have that perforation and be going into shock. Nothing related to the surgical procedure of a hip replacement, but because they've had a perforation from an ulceration that is in their stomach or their duodenum. So look at these, significant number, 14 million patients every year are hospitalized. That have peptic ulcer, and close to 500,000 that are hospitalized. So good chance that you're going to see GI disorders in your patients in the hospital. The two major causes of peptic ulcer disease is NSAIDs, non-steroidal anti-inflammatories, your Advils, your aspirins, Aleve, etc. What happens with NSAIDs, particularly in NSAID abuse, is that the NSAIDs, because they block the inflammatory response, they also inhibit secretion of mucus in the stomach from that thick mucosal wall. So when you decrease mucus production and excretion in the stomach, that allows the hydrochloric acid to bypass that buffer and actually cause inflammation, irritation, and ulceration to the lining of the stomach. We talked about H. pylori, which is a bacterial infection that causes gastritis. It also causes peptic ulcer disease as well. The wall of the stomach. God, how does it do that? Even though nursing diagnoses are important, probably the most important thing is when we look at the collaborative problems related to peptic ulcer disease. We talked about perforation, we talked about peritonitis and sepsis, and also as that irritation, inflammation, ulcerations, or eroding the wall, perhaps of the esophagus, the stomach, or the duodenum, that could very well lead to hemorrhage as well. So you're going to see the patient potentially experiencing a clinical manifestation such as shortness of breath. That could be as a result of a decrease in circulating red blood cells carrying oxygen. Obesity. I am going to be completely honest with you. When I was in nursing school, we didn't talk about obesity. Obesity was more of a rarity than the norm that we see it today. I never would have guessed that obesity was actually going to become characterized as a disease, but that's where we are today. Obesity is an epidemic in the United States, and the number of patients that we see in the hospital is increasing that have obesity, not only as a comorbidity, but possibly as a contributing risk factor to what brought the patient to the hospital. So look at this. It's actually diagnosed now as a disease. It's a metabolic disease characterized by the accumulation of excess fat to the extent that health is impaired. If we want to look at body mass index as an indicator of obesity, a body mass index greater than 30 is considered to be obese. Here's a startling statistic. 66% of all adults in the United States are overweight or obese. causing major problems, major complications. Obesity, we said, is accumulation of fat to the extent that health is impaired. How does it impair health? Look at that. These are the disorders and diseases directly associated with obesity. Type 2 diabetes, asthma, hypertension, coronary artery disease, cerebral vascular accidents or cardiovascular diseases, coronary artery diseases, cancers. I have a friend whose wife just passed away. She had renal carcinoma. One of the primary risk factors for renal carcinoma was obesity, and that patient had that direct risk factor in pulmonary emboli. So we hope that we can encourage our patient to change their lifestyle. Lifestyle habits are the primary cause of obesity. Sedentary lifestyle, poor eating habits, high-fat diets. And so we look at trying to control a patient through diet and exercise to decrease the obesity and hence decreasing the risk of some of the other related diseases that we previously talked about that happen as a result of obesity. But if that doesn't work, there are medications now. There is a handful of medications that are FDA approved that are going to help to decrease obesity in patients. Orlistat is one. Orlistat is a medication that prevents digestion of fats. You know what? We need fats. We need fat in our diet. We need fat for sex hormones. We need fat for membrane production, cell membrane production. And so we don't want to eliminate fats from our diet. Lorcaserin is another type of anti-obesity medication that's been approved by the FDA. That medication, when they take it, gives the patient a feeling of fullness, what we call satiety. And even though they've eaten a small meal, when they take that medication, they feel full, so they don't want to eat as much, or they don't feel the necessity to eat as much. When those don't work, the pharmacologic and lifestyle changes, then we're forced to go to something a little more dramatic, because obesity is at some point going to be threatening the patient's life. So then we go to what's called bariatric surgery. Your textbook has a great representation of the number of different bariatric surgeries that are possible, from banding to removing 2/3 of a patient's stomach. But they all of the different bariatric surgeries have the same common outcome, which is they decrease the size of the stomach or the volume of the stomach, thereby decreasing how much food a patient can ingest. What we have found, though, with now longitudinal studies, long-term studies on bariatric surgery, it is not the panacea we thought it was. In fact, bariatric patients that have experienced bariatric surgery have the potential to put all that weight back on, even though they still have 2/3 of their stomach removed. Many of them are addicted to food, maybe use food as a comfort measure, and a lot of the addictions have to do with the patient craving sugars, craving fats. So even though they can't eat a lot of them, they may eat constantly or frequent high fat, high sugar food to appease that craving that they might have. And students have given me examples of loved ones who have lost 180, 200 pounds eventually over several years, just to gain that back and more, even though they've had the bariatric surgery, which was supposed to eliminate the problem of obesity. So it's sad, and I'm not undermining it. Lot of causes, and any addiction is difficult to break. But what I am saying is that it is something that we need to address in the United States. The number of school-age children, the percentage is very high. And so all of those school-age children that are obese now, they're going to grow up and they're going to have these chronic problems, and we're going to continue to have a growing mess with healthcare, and the number of patients that are going to have one or more chronic diseases that they're living with. I mentioned that patients who have undergone bariatric surgery, they're not out of the woods. They do continue to have problems, and one of the ongoing problems that the majority of patients that have had bariatric surgery experience is what we call dumping syndrome. Dumping syndrome happens because of the rapid dump of food from the stomach into the large intestine, into the small intestine. Remember that we noted that the stomach will usually contain food contents for about 30 minutes to an hour. Well, let's say that you ban the stomach, significantly reduce the volume, maybe even eliminate half or 2/3 of the stomach. That food is going to go right from the stomach into the small intestine. And the small intestine is going to send out all kinds of signals that they're in the presence of food, and an overwhelming presence of food in a short period of time. That triggers different neurologic responses, and some of those responses cause the patient to feel such uncomfortable clinical manifestations as fullness, weakness, fainting, dizziness, diaphoresis, cramping, diarrhea. And dumping syndrome oftentimes comes in two phases. The early phase, which is the representation of the symptoms I just talked about, and then a later phase, like more than an hour later, that results in the patient having a significant quick spike upward in their blood glucose levels, hyperglycemia, and the clinical manifestations that go with that. Then the pancreas over responds with a hypersecretion of insulin, and now all of a sudden our patients go from clinical manifestations of hyperglycemia to clinical manifestations of hypoglycemia. So very miserable. And a student in recent years relayed to me that she had that done, and it had been multiple years, and she still experiences dumping syndrome. All right, now we're going to be moving to lower GI disorders. All right, let's talk about diarrhea. I mean, what would a GI lecture be without talking about diarrhea? The way that I would like to define diarrhea is is an increase in the liquidity and the frequency of stool over the patient's norm. An increase in both frequency and liquidity of a patient's stool over what their normal bowel pattern would be. So as we know, there's any of a number of reasons that might cause diarrhea. The concern with diarrhea is the potential for complications. Some of the complications that you've been made aware of already several times this semester, including in college lab, have to do with dehydration, have to do with fluid volume deficit. The major organs of the body obviously require perfusion. They require perfusion of oxygen, perfusion of nutrients, elimination of waste products. So diarrhea can lead to fluid volume deficit, which can lead to hypovolemia, which can lead to hypovolemic shock. Hypovolemic shock can result in death. So getting back to an original slide, over 240,000 people die every year from GI disorders. Do we think that anyone ever died from diarrhea? Yes, of course. They have, from fluid and electrolyte imbalances. And on the other side of the spectrum from diarrhea is constipation. So let's use the same parameters for constipation in defining it. Constipation is a decrease in the frequency and an increase in the formness or hardness of a patient's stool over their norm. over their norm. So just like we talked about diarrhea having potential complications, constipation does as well. Constipation is not a benign diagnosis. A patient who is constipated, again, for any of a number of reasons, if that goes unchecked, uncorrected, that patient can then experience what's called an impaction. Think about that. The majority of the water and electrolytes are absorbed in the large intestine. With constipation, that fecal matter is slowing and is locking down in an area, which allows for an increase in absorption over the norm of fluid out of that fecal matter. Then it becomes very hard, and that's called an impaction. It can become almost rock hard. So everything that is proximal in that large intestine to that impaction is going to accumulate. That's going to be fluids, fecal matter, gases. That's going to cause a distension of that bowel. And if that goes uncorrected and unchecked, that distension could lead to a perforation. That perforation is going to allow the unsterile, bacterial-laden fecal matter to leak into the sterile peritoneal cavity, causing peritonitis, causing bacteremia, causing sepsis, septic shock, and death. So the question is, of those 240,000 individuals that die every year from constipation, from GI disorders, do we think any of those have ever died from constipation? Yeah, absolutely. You better believe it. So this is interesting on our slide here. We're just looking at medications. You know, these are pharmacologically induced causes. These are medications we gave to treat something else that the patient might have had. So I have a saying I like for students to incorporate into their memory bank, that for every intervention, there is a correlating set of potential complications. For every, even the most minimally invasive intervention, there is a correlating set of potential complications. So look at these complications, are these medications. All of these different medications can lead to constipation, which can lead to impaction, which can lead to obstruction, which can lead to perforation and death. Some of the diagnostic studies that we employ, we being the healthcare community, to help to diagnose and to treat lower GI disorders are barium enema. So just like we used, remember, barium swallow would be for upper GI, barium enema is for lower GI. And this is just an X-ray that is showing the results of a barium enema. I'm not claiming to say what the diagnosis is here, but just look at that barium. That's why we continue to use it. I mean, look how that brightens up. It brightens up like the 4th of July. Okay, lower GI endoscopic studies. We talked about endoscopic studies with upper GI. Primarily, we mentioned EGD and ERCP. The two primary lower GI endoscopic examinations are a sigmoidoscopy. The sigmoidoscopy is a visualization of the most distal section of the large intestine, which we noted was called the sigmoid colon. So a sigmoidoscopy is just visualizing the sigmoid colon, so it obviously does not have to be as long and as invasive as a colonoscopy, which is going to visualize the entire length of the colon. And the colonoscopy is the endoscopic exam, which will visualize the rectum, the anus, and the entire large colon. For those of you who are listening to this presentation, who have had the opportunity and the pleasure of having a colonoscopy, as I have, I think that you will agree with me that it's not the actual procedure that's the problem, but it's the prep. I know from my experience, the prep was horrible. And I've had to go through it twice now. Neither one was anywhere close to a pleasant experience, but it is important. Obviously, if you're visualizing the colon, the most important thing is to make sure that the colon is clear, so that the endoscopic exam can actually visualize the mucosa and the lining of the entire large bowel. So if you have a patient that you're caring for that's going down for colonoscopy, it's very typical that the patients might be NPO for, from, midnight until the time of the exam. They're on a liquid diet for 24 to 48 hours before they have the procedure. um, and something that is important, that if your patient is scheduled for a colonoscopy, you can bring them down there. You cannot bring them down for that colonoscopy if they haven't completed the prep. The doctor will not be happy. So that's something that's very important to monitor and make sure that they're taking the prep. If they refuse the prep, you have to cancel the exam, or at least let the physician know who is going to perform the exam. The post procedure, most colonoscopies are done on an outpatient basis, obviously. But post procedure, because the patient has had significant sedation, it is a law that the patient cannot drive or operate heavy equipment for the next 24 hours. So if you do have a patient that is going to be discharged, they cannot be discharged until someone is there and identifies themselves as the driver of that individual to get them back to their place of residence. Any intervention, there's a correlating set of potential complications. It would be the same with the colonoscopy, the endoscopic exam. The endoscope itself could cause a bleed. If you're trying to push past an obstruction or a curvature in the bowel, there's always the potential for perforation, which we've already talked about, the consequences of having anything that is in unsterile nature within the large bowel passing over into the sterile peritoneal cavity. So it says that you're to begin fluids and food slowly, and then make sure that we prevent our patient from getting nauseous. And again, there's always that risk of aspiration, particularly in the older patient. All right, when we're looking at GI disorders, oftentimes we're going to be helping to base our diagnosis on the location and the type of pain that the patient is experiencing. We look at the abdomen divided up with the umbilicus being the center into 4 separate quadrants: right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. So let's just think about what it is that we actually might see in the right upper quadrant. So in the right upper quadrant, what do we have that is up there? So we have a liver. Liver is going to be in this area right here. Your gallbladder is going to be in this area in the right upper quadrant. The left upper quadrant, we have our stomach. And remember, superimposed behind the stomach is going to be the pancreas. The right lower quadrant, this is where the most distal section of the small intestine, which is the ileum, where the ileum actually will join up with the large intestine. And the large intestine is the cecum, the most proximal part of the large intestine. There is a valve separating the small intestine from the large intestine. That's the ileocecal valve. Also, as you recall, we have coming off of the cecum, we're going to have our appendix, which is going to be down in the right lower quadrant area also. The left lower quadrant is where we had the most distal section of the large bowel, and so that's going to be where your sigmoid colon is going to be located. When performing our assessment on the patient, for example, with a lower GI disorder, one of the most important things we will assess is the patient's pain. Remember, we need to be specific about pain. We ask a patient, where they're experiencing pain. They might say their stomach. Well, for them, the stomach is the entire all four quadrants. So what I like to do is ask the patient, if you could take one finger and point to where your pain is most intense, where would that be? And boom, they point to a specific quadrant. Ask the patient if they had to rate the pain on a scale of 1 to 10 and describe what the scale actually means, with 1 lowest, 10 highest, and ask them how would they rate it. Ask them to describe the pain. Don't give them a multiple choice question, which is, would you say that your pain is dull, ache, sharp, stabbing? You said, could you please describe your pain for me? One of my students shared in a post-conference where she was assessing her patient's pain in the hospital who had a there was an ascending urinary tract infection, and she said, "Can you describe the pain?" The patient said, "Well, every time I urinate, it feels like shards of glass are scraping through my system." And that was a pretty descriptive pain analysis there. That would not even been under select all that apply. That one was excellent. So we're also going to be looking at any nausea, vomiting. The patient has an appetite, does not have an appetite. Objectively, vital signs. I cannot stress enough the importance of a nurse getting their own vital signs. I have been a nurse for 30 plus years, and I can't tell you the number of times when I have seen an unlicensed personnel get incorrect vital signs or record incorrect vital signs on a patient. It takes less than a minute for an experienced nurse to get a set of vitals. They have to go in and see the patient and do an assessment anyway. They're called vital for a reason. They're not called suggestions or helpful hints. They're vital signs. Perhaps it's my critical care background and trauma background, but vital signs are the first indicator oftentimes that something very serious is going wrong with the patient. And so I always encourage you, whenever possible, you get your vitals. Don't, ask an unlicensed personnel who happens to have 15 patients that night, hey, can you get a set of vitals for me in 15 when you get a chance? Because they've got all kinds of things that are going on, and they may even forget. I've seen them transcribed. I've seen some PCAs put the same respiratory rate on every patient every time, week after week. And so get your own vital signs. Patient position is important. Bowel sounds, again, are the bowel sounds present? Are they normal active? Are they hyperactive? Are they hypoactive? Tinkling, rushes, gurgles, etc. All very important. Hone your nursing assessment skills. Even right now, you've got one patient for hours. Do a complete and thorough assessment on your patient. Even if your patient is normal in their assessment, you do 50 normal assessments and you get to that 51st assessment and something is wrong, you know it. It jumps out at you. You've done the 50 normal assessments. That 51st is like, wow, this is different. Something is going on here. All right, continuing with lower GI disorders, we'll talk about an appendicitis. Itis is inflammation, appendix, inflammation of the appendix, appendicitis. It is considered to be the most common cause of acute abdominal pain, in a patient. All right, continuing with lower GI disorders, we're going to talk about the appendix. When it becomes inflamed, we call that an appendicitis. Itis is for inflammation. When we were looking early on about the anatomy of the GI system, we said that there's the most proximal section of the large intestine that's called the cecum. And then coming off the cecum is where you'll have your appendix. The fecal matter travels from the distal ileum across the ileocecal valve into the cecum, and then from the cecum down, filling into the appendix. Peristalsis will then empty the appendix and empty the cecum of fecal matter, and it will continue up the ascending colon. For whatever reason, sometimes what happens is that there is uh, um, an opportunity for fecal matter to become trapped in the appendix. When the fecal matter becomes trapped in the appendix, as the peristalsis empties the rest of the appendix, the fecal matter stays behind. That fecal matter begins to then decompose. That decomposition leads to a release of bacteria, which triggers the inflammatory response. And with the inflammatory response and the rush of white blood cells and blood and fluid to that area, eventually that's going to expand the appendix beyond what it can hold, and the appendix is going to rupture. And then that's what's being shown in down here is now that bacteria-related fecal matter is now emptying into the sterile peritoneal cavity, causing an inflammatory response of the lining of the peritoneum. So we have peritonitis, and that facilitates uptake of bacteria into the bloodstream and the vasculature. That's called bacteremia. Travels to other organs of the body. We have sepsis, then we have organ failure, we have septic shock, and we have death. I don't know if I told you before, but 240,000 patients die every year from GI disorders. Do you think anyone's ever died from a ruptured appendix? Yeah, absolutely. You better believe that they have. So we need to be on top of it, and we need to be perceptive of changes in our patient. Again, they might come in for something else, and suddenly they're starting to complain of right lower quadrant pain. They have nausea, vomiting, maybe they get a little fever, an increase in white blood cell count. We need to monitor just not what the patient is primarily in the hospital for, but the entire patient. It's what we do. We have a holistic approach to our care. So how does an appendix manifest itself on a patient? Well, initially, it starts out and it is a generalized pain in the periumbilical area around the umbilicus. That's what it means by the periumbilical, so around the umbilicus. And then over a period of time, that pain begins to gravitate to a midpoint between the iliac crest and the umbilicus. Not only is the pain gravitating to that area, but it's also increasing in its intensity. And so that point, midway between the umbilicus and the iliac, is what is called the McBurney point. Now, that isn't an all or nothing. It isn't every time, all the time, that the pain radiates to the McBurney point. But it does happen quite frequently. It is what would be considered to be a common manifestation of a patient that is suffering an appendicitis. The pain for the patient is more intense, not when you're palpating and pressing down over the McBurney's point, but when you release it and the abdomen rebounds over that area that you're pressing. It's on the rebound that tends to be the most intense level of pain. The patient comes in oftentimes in a flexed position, so we said be aware of the patient's position. They tend to almost be in almost a type of fetal position that tends to alleviate the pain. The best way for diagnosing an appendix is to actually have a diagnostic study. The CAT scan is the preferred diagnostic study for diagnosing and appendicitis. You want to get a good assessment, get a complete history and physical on the patient. Look at the white blood cells for elevation. Look at the differential. The SED rate here stands for erythrocyte sedimentation rate. Erythrocyte sedimentation rate is a laboratory study. It's a study serologic from the blood. And what that is looking at is a premature increase in the breakdown of red blood cells. Red blood cells have their normal lifespan where they peak, and then the lifespan ends, and then they begin to disintegrate or break down. This breakdown is the sediment, and there's a normal amount of erythrocyte sediment because of the normal life of a red blood cell, and then they're being replaced by fresh new blood cells. But for whatever reason, when there is a spike in inflammation, a severe inflammatory response, it tends to prematurely break down the red blood cells, and that's what we pick up in an increase in the erythrocyte sedimentation rate, otherwise known as the SED rate. So this is a good slide to know. For preoperative care, obviously we don't want to feed the patient. We don't want to feed any patient preoperatively, but particularly a patient that has a GI disorder. We're going to initiate an NPO order or carry out an NPO order on our patient. IV fluids as prescribed. Monitoring for shock. Shock would come after a perforation. Let's just take a step back and say, okay, what would be some of the clinical manifestations of shock? Well, shock is represented by a number of very classic clinical manifestations or signs and symptoms. One is alteration in mental status. The patient is less alert. The patient is confused. The patient is agitated. The patient is lethargic. It would be an increase in the patient's heart rate. They become tachycardic. They become tachypnic. And then they become hypotensive, hypotension. And as the kidneys begin to fail, you have a decrease in urinary output. So altered mental status, tachypnea, tachycardia, and decrease in your urine output, and also hypotension. Those are signs for shock, and you need to be on top of it then and seeking immediate medical attention for your patient. We're going to monitor again for our patient preoperatively for sudden changes in pain. If you walk in the room after the patient has been writhing and rolling back and forth in a fetal position, stating a pain level of 9 out of 10, and you walk in the room 15 minutes later and they're smiling at you and wondering if they can order a food tray because the pain is gone, that is not a good sign. What that more often than not means is that the appendix is ruptured. And now we're going to move from appendicitis to a ruptured appendix to peritonitis and potential septic shock. So that's why we're monitoring for shock. Whenever the patient is manifesting signs and symptoms of shock, those that we just mentioned, and the physician has a series of orders that they would like you to implement. And let's say that they ordered pain medication on your patient, they ordered NPO status on your patient, they ordered IV antibiotics on your patient, and they ordered IV fluids on your patient. The most important order, or the order that the nurse should fulfill first, is always going to be your IV fluids. People might want to say, well, wouldn't we want to get them out of pain? Well, bottom line is if we don't correct the shock and if we don't increase the circulating fluid volume, it's not going to matter. Your patient's not going to be in pain because they're going to be dead. If we don't have sufficient fluid volume, it doesn't matter if we give them IV antibiotics because the antibiotics aren't going to be able to circulate. So always want to think with shock, you want to think that the first order that you're going to fill is going to be getting those fluids running on your patient. Patient preoperatively, it seems like if we lay them on the right side, which seems somewhat counterintuitive because that's a sign the appendix is on, but if we lay them on the right side, they often get relief from their pain. And we want to place the patient in a low or semi-Fowler's position to promote comfort. Ice packs are something that are often ordered. Put ice packs onto the right lower quadrant. Again, they have to be ordered, and it's typically 20 minutes on, 20 minutes off, 20 minutes on, 20 minutes off. Avoid laxatives, avoid application of heat to that abdomen preoperatively for a patient diagnosed with an appendicitis. All right, post-operative care for a surgeon, excuse me, for post-surgery for an appendicitis. Now it is not low Fowlers, but high Fowlers. Let's think about that. If you have an incision, an abdominal incision, and all of a sudden you go in and say, I need to move you up in bed, and you lower the head of the bed flat, the more you lower that head, the more stretched the stomach is going to be, the more tension is going to be on that incision. So post-operatively, we want to keep that patient in a high Fowler's position, so we're not stretching and putting tension on the incision by lowering them down. Pain management, again, IV fluids are important to make sure that we have the patient topped off and that we're getting good perfusion to the major organs of the body. Monitor vital signs. Vital signs are so important. Again, this is a patient post-operatively that there could be complications from surgery. There could be peritonitis. There could be sepsis. So monitor your vital signs, and again, future nurses, when possible, get your own vital signs. I've seen too many nightmares over 3 decades with PCAs who shouldn't be the ones getting vital signs on patients. All right, we've talked about peritonitis quite a bit during our presentation. Peritonitis is a localized or generalized inflammation of the peritoneum. Again, peritoneum and itis. Itis is inflammation, so an inflammation of the peritoneum. Common causes would be the rupture of the colon. We said that perforation is a potential issue with GI disorders, peptic ulcers, diverticulitis, appendicitis. Pancreatitis can cause it, penetrating trauma, whether that's a gunshot wound or a knife. And then a postoperative breakage of an anastomosis. What is that? Well, anastomosis is when a surgeon removes a certain section of a patient's diseased bowel. They remove that section of diseased bowel, and they actually go a little bit further out into the healthy margins. They'll cut that section of the diseased bowel out, and then they'll bring the two healthy sections of the bowel together, and then they'll sew them in place, or suture them in place. Sometimes at that point of anastomosis, that's what it's called, an anastomosis, bringing those two healthy sections together, that maybe a suture might break or it might stretch. And so now you have the opportunity for leakage of the fecal matter out into the sterile peritoneal cavity. And again, that causes inflammation of the peritoneum, which is peritonitis. All right, clinical manifestations of a patient with peritonitis. The classic sign is local muscular rigidity. Sometimes we call it BORD, B-O-A-R-D, board-like rigidity. What happens in peritonitis is that inflammatory response causes that area of the abdomen, which tends to be directly over where that perforation is, becomes hardened. You might have, this quadrant soft, this quadrant soft, this quadrant soft, and then you get to the quadrant of pain over where the peritonitis is located, and it is hard. That part of the abdomen is hard, almost board-like hard. You'll have diminished bowel sounds and possibly absent bowel sounds, fever, chills, because you've got an infection going on, a peritonitis. Progressive abdominal distension with increasing pain. So now all of a sudden we're now going to look at some of these signs and symptoms which are indicative that the peritonitis is going into sepsis and septic shock, tachypnea, tachycardia, pallor, which is a change in the flush and the coloration of your patient, restlessness from the altered mental status, increase in white blood cells. To that you could add a decrease in urinary output. So what we're doing is we're monitoring for signs and symptoms of hypovolemic shock, decreased blood pressure, decreased urine output, increase in respiratory rate, increase in heart rate, change in the level of your patient's consciousness. This is when we need to catch it. We need to catch it when we're first having these vital signs presenting themselves as abnormal. That's why we do not want to routinely and with a cavalier attitude, we don't want to delegate vital signs to an unlicensed personnel. Very, very critically important. If I haven't told you, 240,000 people die every year from GI disorders. Do you think anyone has ever died from peritonitis? Absolutely. You better believe that they have. Even though that wasn't the primary admitting diagnosis when they came into the hospital, it developed while they were there, while they were under your care. What I want to point out on this slide is an X-ray as far as a diagnostic study goes. When we're looking at patients' lungs, we want to see this dark area here. That means that there's free air in there. And that's what we want to see when we're looking at the lungs. What we don't want to see is this right here, which is free air in our patient's abdomen or in our patient's belly. That is not supposed to be there. It's not supposed to be free air, but air is leaking in there from some sort of a perforation in our patient's bowels. So that's an excellent illustration of what we don't want to see on a chest x-ray. All right, so with peritonitis, we're going to make sure we keep our patient topped off with fluids. Once again, monitoring closely for fluid volume deficit, which could lead to hypovolemic shock. We've talked about shock, and again, the importance of making sure that we keep the fluids running, or that's the first order of business if we have a list of orders and a patient suspected of shock. Or high candidate for shock, is we want to get those fluids running on our patient. And it doesn't matter from your perspective right now what fluids are ordered. So we may, from a testing perspective, say normal saline, lactated ringers. We're not asking you to determine whether that's the appropriate type of fluid, but the fact that it is fluid, and that is important to prevent the patient from going into shock. Possible NG tube placement. Here we go again. Monitor vital signs closely. This is not the patient to say, hey, to your PCA, can you get a set of vitals in 24 when you get a chance? Because something could happen. There could be a rapid response. This PCA already has, 12, 15 patients they're dealing with. They've got to discharge a patient and take them down. Someone is asking them to run to the tele unit to get a monitor for them. There's 3 call lights going off with patients that are on the toilet. Get your vital signs. Grab yourself a Dynamap and go in and get your vital signs on your patient. I can't tell you how many times it's going to pay off for you and worth that 1 minute of extra time that you're taking. And so again, why are we monitoring vital signs so closely? We're watching for signs of sepsis and shock, alterations in mental status on your patient, decrease in your blood pressure, decrease in urinary output, increase in your heart rate, and increase in your respiratory rate. All right, the next lower GI disorder we're going to talk about is inflammatory bowel disease. So inflammatory bowel disease is actually an umbrella term. Underneath that umbrella term of IBD, not to be confused with IBS, IBD, inflammatory bowel disease, are 2 different types of GI disorders. One is ulcerative colitis, and the other one is Crohn's disease. And we'll talk about them individually and in some detail in the upcoming slides. But just generally, ulcerative colitis is an inflammation and ulceration of the colon and the rectum. So the term colon gives you an idea of where this is going to happen. Colitis in the colon. So ulcerative colitis only happens in the rectum and the colon. Whereas Crohn's disease, which also falls under the umbrella term of inflammatory bowel disease, Crohn's disease is an inflammation, but it can happen in any segment of the GI tract from the mouth all the way to the anus. So what we know about inflammatory bowel disease, and again, we're talking about both Crohn's disease and ulcerative colitis, is that they are autoimmune diseases. For whatever reason, the body's immune system attacks the normal flora of the patient's intestines. There are some triggers, but they're not universal across patients. The problem is that it is a chronic inflammatory response. So any organs, any anatomical structures that are repeatedly exposed to the inflammatory response are going to be affected by that. And what happens is it begins to destroy the integrity, the structural integrity of the tissues of that particular organ. And as the structural integrity begins to break down because of exposure to the inflammatory response in a prolonged manner, that is called remodeling. And if you disrupt the integrity of the tissues, you're going to disrupt the function of the organ. And that is exactly what happens. Okay, I'm going to compare and contrast Crohn's disease from ulcerative colitis here. Crohn's disease, we mentioned, can affect a patient anywhere from the mouth all the way down to the rectum. Crohn's disease can skip segments of bowel, meaning that you have diseased bowel followed by sections of healthy bowel, followed by diseased bowel, healthy bowel. So it's segmental. You can have healthy bowel followed by diseased bowel, followed by healthy bowel. Crohn's disease will typically manifest itself initially in the distal ileum, so right in this area. And patients will experience then what kind of pain? Well, they'll experience right lower quadrant pain. So right lower quadrant pain, because the primary place it first manifests itself is in the distal ileum. The ulcerations caused from the inflammation in Crohn's disease can actually penetrate the entire bowel wall thickness. So the ulcerations from the inflammatory response in Crohn's disease can penetrate the entire bowel wall thickness. If it can penetrate the entire bowel wall thickness, guess what that means? That there's a potential that it can cause perforation, which is then allows for a leakage of the bacterial-laden fecal matter to leak into the steroperitoneal cavity, and we learned the complications of that. With Crohn's disease, sometimes Crohn's disease patients will develop fistulas. Fistulas are these little finger-like projections. They're finger-like projections that grow out of the bowel wall. The finger-like projections are hollow, like hollow cavities or hollow tubes that grow out of the intestinal wall, and they go different places. Sometimes they'll go to the surface of the patient's abdomen. So you have fecal matter that's leaking on the outside of the abdominal wall. Sometimes in females, it'll go into the vaginal area so that you'll have fecal matter leaking into the vaginal area. Again, let's remember this patient population and the age and self-image that we were talking about before. Crohn's disease manifests itself in an increase in output and an increase in frequency of stool. So you would call it diarrhea. So they have diarrhea, but their stool typically does not contain blood. Again, typically Crohn's disease, the stool of a Crohn's disease patient does not contain blood typically. It is does contain pus and contain mucus. All right, so let's compare and contrast what we just learned about Crohn's disease with ulcerative colitis. Unlike Crohn's disease, which can manifest itself all the way from the mouth to the anus, ulcerative colitis only manifests itself in the colon. That's why it's called colitis. It only will manifest itself in the colon. Unlike Crohn's disease, which skips segmentally, healthy bowel, disease bowel, healthy bowel, disease bowel, there is no segmentation in ulcerative colitis. It will typically start in the sigmoid area and will rotate up uniformly without skipping segments of bowel. It usually will advance and then eventually it will come all the way over, and it can encompass the entire large bowel, the colon. Unlike Crohn's disease, in which the ulcerations and the inflammation can penetrate the entire bowel wall, for ulcerative colitis, they only affect the innermost layer of the large intestine. So where they won't typically, you're not going to have perforation of bowel from ulcerative colitis. What you will have, though, is that you will have an increase in diarrhea, and you're going to have bloody, liquidy stools. Bloody stools is the classic sign differentiating ulcerative colitis from Crohn's disease. Somewhere in the neighborhood of 14 to 20 bloody stools every day. In ulcerative colitis, you're not going to have fistula development. All right, very good. Okay, and this slide just outlines what we talked about in the previous slide. So you can imagine with diarrhea that we have with Crohn's disease. Again, we're talking about Crohn's disease here. That the stool does contain mucus and pus, but typically does not contain blood. You're going to have cramping pain, oftentimes after meals. Remember, where is that located? Right lower quadrant. Why is it the right lower quadrant? Because that's predominantly where Crohn's disease initially shows up, which is in the distal ileum in the right lower quadrant. Now, because Crohn's disease can affect any area in the GI system from the mouth to the anus, it can happen in the small intestine. So with the inflammatory response happening, let's say in the ileum, you do have the potential, because of the inflammatory response and the tissue remodeling from exposure to the inflammatory response, some scarring, you can develop small bowel obstructions. So remember, small bowel obstructions can develop from Crohn's disease, but small bowel obstructions cannot develop from ulcerative colitis. Why? Because ulcerative colitis only affects the colon, not the small intestine. Likewise, well, down here, we'll see, well, you might see steatorrhea. Remember, for a while back, we talked about steatorrhea, and what is steatorrhea? Fatty, greasy stools as a result of fat malabsorption. So let's say in that part of the ileum that normally absorbs fat, in that absorption process, that's diseased, and so fat will continue to go through the system, and we'll see steatorrhea, which is fatty, greasy stools. We're not going to see steatorrhea from ulcerative colitis. Why? Because it only affects the colon, and the colon is not where fat absorption happens. The colon is where water absorption and electrolyte absorption happen. And actually it's in both, more predominantly, I would say, in Crohn's disease, but both ulcerative colitis and Crohn's disease, I don't know, because of the autoimmune component, whatever it might be, there is the potential that the patient will develop uveitis, which is an inflammation of the uvea, which is inside of the eye. And yes, I know that the GI has no acquaintance with eyes, but it's just one of those strange things that happen. We've had patients in the hospital that have had uveitis while they have a flare-up in their Crohn's disease, and they have had to receive corticosteroid drops, eye drops. All right, so again, when you have increase in liquidity and frequency of stools, we're going to monitor for dehydration and also monitor for electrolyte imbalance. I mentioned that I like diets. That's something that we help our patients with and help them maintain appropriate diets. So When we're talking about a patient that has an increase in liquidity and frequency of stool, we also have a destruction and a breakdown and an inflammation of tissues and that line the intestinal tract. Foods that we're going to encourage for that patient are going to be those that are high in protein. Why high in protein? Because we want to repair the tissue damage that has happened, and we want to promote growth of new and healthy tissue. And low in fiber. Why do we want low in fiber? Because fiber helps motility. Fiber helps passage of stool. We have no problem with passage of stool. In fact, we've got too much passage of stool. So we want high in protein and calories, but low in fiber. Again, looking at ulcerative colitis, we remember that ulcerative colitis only affects the colon. It typically will first manifest itself in the lower segment of the large intestine, which is the sigmoid colon. So oftentimes the pain is going to manifest itself first in a patient with ulcerative colitis in the left lower quadrant. And here we go. The main clinical manifestation that differentiates ulcerative colitis from Crohn's disease is that with ulcerative colitis, they have bloody, liquidy diarrhea, sometimes up to 10 to 20 a day. Left lower quadrant pain because it typically will first manifest itself in the sigmoid colon. Another thing at the bottom here, so if we're having lots of blood loss, then we're going to have a decrease in both hemoglobin as well as our hematocrit. And the only thing I want you to recognize in this slide is that there is a very significant life-threatening complication of ulcerative colitis, and that's called toxic megacolon, where there's just a severe blow up of and inflammation and distension of the colon, which it has a high potential for rupture and shock on your patient. Don't have to know the treatment, but just recognize that toxic megacolon is a life-threatening potential complication of ulcerative colitis. When we talk about surgical interventions for patients with inflammatory bowel disease, we typically will say that surgical interventions are contraindicated in patients that have Crohn's disease. Now, that being said, still, approximately 75% of all patients that have Crohn's disease end up having some sort of a surgical procedure. So what do I mean that it's contraindicated? The reason is that it's not curative. So a patient that has a diseased section of bowel, let's say that it is the jejunum is diseased from Crohn's disease, and the surgeon, it gets to the point where we're just having repeated small bowel obstructions and some nutrient malabsorption in that area. So the decision may have to be made that we're going to have to resect that section of diseased bowel and then put the two sections of healthy bowel back together. Inevitably, the problem is that once we take out that disease section and we put the two healthy sections together, almost always the Crohn's disease is going to return. And where does it return? Right at the anastomosis, right where we took those two healthy pieces of tissue and decided to sew them together. So it's not curative, but 75% have to have it done. Otherwise, you can't live with a bowel obstruction. And I think they're trying to prevent having to early on, have the patient undergo an ileostomy where they're going to be, carrying a drainage bag the rest of their life. So there are three surgeries that we're going to talk about, and for the purpose of this lecture, we're going to talk about these surgical procedures in response to ulcerative colitis. So when the patient's colon becomes so diseased, so remodeled, that the patient is no longer able to use the large colon for elimination of fecal matter. They have to go to Plan B. So the first one is the cocciliostomy. Cocciliostomy, when you think of cocks, think of a reservoir or a pouch, a reservoir or a pouch. So we're not going to say in this situation what happened to the large intestine and the rectum. All we're going to say is that they're no longer going to use any portion of the large intestine or the rectum for elimination of their fecal matter. So whether they sew it off, whether they remove it, we're not going to say, and it's not important. So a cocciliostomy, since we're not going to use the colon, what the surgeon is going to do is pull down healthy segments of the ileum and create this reservoir or this pouch that you see here. So when the food, fecal matter, which is going to be runny, comes down, it's going to store in this reservoir. They're going to bring the outside of that ileum, they're going to bring the ileum to the outside of the abdominal wall here. And as opposed to just folding it back and creating a stoma, what they're going to do is they're actually going to put in place a one-way nipple valve. The one-way nipple valve allows the patient not to have a permanent drainage bag. But what it does require is that the patient is going to self-catheterize themselves in order to drain out the fecal matter or the waste product. So it is a one-way nipple valve. It's not irrigation. Don't get that confused. Irrigation is only in the large intestine, only in the colon. But this is a reservoir where they bring the outside of the ileum to the outside of the abdominal wall, and they put a one-way nipple valve, and the patient self-catheterizes themselves in order to empty the pouch and fulfill what's needed for elimination of the waste products. Don't see this often. Don't see this very often. One of the major problems, which is a concern of all stomas, type of stomas, is leakage and skin integrity issues. The second type of surgical intervention that we're going to be talking about is a total proctocolectomy with a permanent ileostomy. So total proctocolectomy. So total means complete. Remember procto or proctologist? Proctologist is the doctor who examines the anus and the rectum of a patient. So in a total proctocolectomy colon, the surgeon is going to remove all of the large intestine and is going to remove the rectum and the anus as well. So a total proctocolectomy. Taking the entire, look over here, taking the entire large intestine out and also taking out the rectum and anything that's left of the anal sphincter. They're going to be sewing up and putting a stitch in to sew that up. So now that we're no longer able to use the large bowel to evacuate stool and waste products, once again, they're going to pull down the ileum. But this time, as opposed to creating a pouch, with a one-way nipple valve, what they're going to do is take the end of the stoma, bring it to the outside of the abdominal wall, and create the stoma. So that's a permanent opening, and what that will require is that that patient needs to have a drainage bag. Okay, patient needs to have a drainage bag. So it's a permanent stoma. That is, the fluid will always be running, it will always be liquidy, and the patient will be required to have a drainage bag. We want to always make sure when we have the drainage bag that we empty it when it's 1/3 full. We don't want to risk spilling over or leaking because, like all stomas, as I said, that one of the primary problems is skin breakdown and skin integrity issues around that stoma. Okay, and the third and final type of surgical management is called the proctocolectomy with an ileal pouch and an anal anastomosis. Holy mackerel, that's a lot. Well, let's look at and break this up. So this time it's not a total proctocolectomy, but they are going to remove the rectum and the colon, but they leave the anus in place. So if you see down here, they're going to leave the anus in place. It's still functional. They're going to then pull down, since they removed the rest of the colon and the rectum, they're going to pull down healthy ileum, and they're going to once again create a reservoir. What they're doing is they're recreating the rectum that they removed. And then the final section of that ileum, they're going to sew onto the anus. So they'll sew it back onto the anus. So as the fecal matter comes down here, it's still going to be liquidy. It's going to store in this reservoir. Pressure is going to build up as it fills up. The anal sphincter is going to have the nerve innervations intact. They'll feel that pressure, and the patient can sit on the commode excuse me, and have a fairly normal evacuation pattern of their bowels. Now, it's still going to be liquidy, but they will not have to have a drainage bag, will they? No drainage bag. They'll be able to sit on the commode and relax the anal sphincter and allow passage of the stool. Caveat, important to recognize when you're doing patient education for these patients. This is a surgical procedure, a two-step surgical procedure. The first procedure, surgical procedure, is when they're going to, excuse me, they're going to remove all of the large colon and the rectum. They're also going to create this reservoir, and then they're going to sew it to the rectum. So they'll pull out all of the colon, and then they'll pull the ileum down, create this artificial rectum here, and then sew it to the anus. Well, this right here is going to take about 3 months to heal before it can be used for evacuation of fecal matter. Now, that means that during those 3 months, how are they going to get rid of the fecal matter? Well, what they'll do is they'll take a loop of this ileum and they'll bring it to the outside of the abdominal wall. So if this is the abdominal wall, they'll bring that ileum out to the outside of the abdominal wall, and then they'll loop it back in. And then they'll create a little opening on the end of that loop, a temporary stoma. And so the fecal matter will come down, it'll be liquidy, and then will drip out. So we're going to have a temporary ileostomy that is going to require a drainage bag. However, after 3 months, the second procedure is going to take place, which is going to bring this ileostomy back in. It's going to bring this loop back in. And then the patient is going to be able to have a semi-normal evacuation of their stool. So it's 2 steps. They will not require a permanent ileostomy. They require a temporary ileostomy, and the patient will be able to evacuate their bowels semi-normally and won't require a drainage bag. There are a couple of special considerations when we're caring for a patient that has a stoma. Number one is that we want to always make sure that we're assessing for skin integrity breakdown. Skin integrity breakdown can cause infection, as we know. So if we're looking just at the stoma itself, if we're looking at the stoma, we want the stoma to be pink to bright red. We want the stoma to be shiny, and we want it to be moist. So what we do to help prevent the skin breakdown is we provide a skin barrier to our patient around the stoma. And you can kind of see that outlined in this picture here. The other way that we help to decrease breakdown and skin integrity issues is to prevent overflow of the bag. So we're going to always empty that bag when it's 1/3 full. So if we're employing pharmacologic agents to try to decrease the inflammatory response, the go-to medications are most often steroids. So corticosteroids, steroids just block the entire inflammatory response. Prednisone is your oral version of the steroid, and hydrocortisone, otherwise known as Solumedrol, Solu-Cortef, is going to be your IV. Aminosalicylates are particular and specific to inflammatory bowel disease. Azolfidine would be the one that you would want to learn and be able to apply if you're ever tested on this. So aminosalicylates come. There's like 5 different types of aminosalicylates, and they all reduce inflammation. But what's really cool about them is they reduce inflammation directly at the particular area that is inflamed. It's not systemic. So you might administer them by foams, you might administer them by enemas. And again, that medication goes directly to those anatomical structures that are inflamed and don't affect the rest of the body. Um, um, the biological therapies are becoming more and more utilized, and you'll begin to see commercials for those. What they do is they block the inflammatory response at the tumor necrosing factor. You have other immunosuppressants. Infliximab is a medication that you're going to see for inflammatory bowel disease. And that is an example of a biologic therapy. Okay, we're moving on from inflammatory bowel disease. You guys are all doing great. Hang in there with me. But we're next going to talk about diverticulitis. Diverticulitis, itis, is inflammation, diverticula. So inflammation of the diverticula. What is a diverticula? A diverticula, as you can see over here on this slide, is an outpouching. It's a weakening and an outpouching of the large intestinal wall. Typically, where we're going to see diverticula is going to be in the sigmoid colon. Again, left lower quadrant. So as the fecal matter passes through the sigmoid colon with peristalsis, it's going to fill these diverticula, and then with peristalsis, it's going to empty and it's going to move on. Sometimes, however, different non-digestible food gets caught in there, and it might be a peanut, it might be a popcorn kernel. Gets caught in there, and then as the fecal matter passes through, the fecal matter attaches on to that nut, that undigested piece of food product, and the fecal matter gets trapped in there. And just like the fecal matter that gets trapped in the appendicitis, eventually it's going to decompose, it's going to release bacteria, grow and release bacteria, it's going to cause the inflammatory response, and it's going to cause infection and inflammation and swelling. And if these outpouches swell to a certain level, they have the potential to develop microperforations. That perforation is then going to allow the fecal matter to seep from the intestinal, inside the intestine, out into the peritoneal cavity, and then you have peritonitis, bacteremia, sepsis, septic shock, and death. So we need to be aware of that. We need to monitor, aware that a patient has diverticula from a previous colonoscopy. Recognize left lower quadrant pain could be a symptom of diverticulitis. Monitor for signs and symptoms of shock in that patient. So we said early on, I don't know if you remember, 240,000 patients die every year from GI disorders. You think anyone's ever died from diverticulitis? Yep, you got it. All right, clinical manifestations, signs and symptoms of a patient that has diverticulitis. Pain, where? Left lower quadrant. Why left lower quadrant? Because it typically manifests itself with diverticula starting in the sigmoid colon. So you're going to have pain. We're going to potentially have chills and low-grade fever with the infection, distension and tenderness, elevated white blood cells with the infection. Look at this. Now we have the potential for perforation, peritonitis, and shock if left untreated. All right, so we're talking about how do we care, medically care, nursing care for a patient that has diverticulitis. We can't feed them. We don't want to feed them and contribute to the problem. So the patient could be NPO, maybe progressing, if tolerated, to clear liquids. Listen to bowel sounds. Listen for bowel sounds and document the bowel sounds. Are they normally active? Are they hypo, hyper? Are they distant? Are they absent, etc.? Pain management for that patient. As we said in the previous slide, the pain can be severe. Fluid replacement, particularly when we might be looking at a perforation of the bowel. Antibiotic therapy for the infection, prevent complications, sepsis, septic shock, and death, fluid volume deficit, etc. So again, if you had an opportunity and you were going to fulfill the orders written for your patient with diverticulitis and suspected perforation, and you have the option to first hang the antibiotics, to secondly administer pain medications, thirdly to put them NPO, or fourth, the first thing, to put them on IV fluids. The answer is going to be IV fluids. We've got to keep the circulation and we've got to perfuse the major organs of the body, particularly when we're looking at shock. One other thing with shock that might be indicative of hypovolemic shock from a loss of fluid is when you have orthostatic hypotension. So remember that. Also look for orthostatic hypotension is an indication oftentimes of fluid loss. Orthostatic hypotension is when the patient has a change in 20 millimeters of mercury less in the systolic, when the patient goes from a sitting to a standing position or lying to a sitting position. The systolic will drop by at least 20 milliliters of mercury, and or the diastolic will drop by 10 millimeters of mercury. So look for that. So clinical manifestation, patient sitting is 120 over 80, patient standing goes down to 100 over 90. All right, orthostatic hypotension. And then with orthostatic hypertension, we look for the patient possibly experiencing a syncope episode and falling, and so they're a fall risk. And last thing we want is the patient to get up and get dizzy, have a syncope episode, fall, and break a hip. Okay, I said I love my diets. So a patient that has diverticulitis, the diet ordered would be a high fiber diet and low fat diet. Particularly looking at the high fiber diet. Well, why do we want high fiber diet? Fiber does what? Fiber helps the motility of the fecal matter. We want to keep the fecal matter moving through that sigmoid colon. We don't want it resting in there and potentially filling up the diverticula and getting it trapped. So remember, when we had inflammatory bowel disease, we wanted a low fiber diet. There's no problem with motility when you've got diarrhea, but we want a high fiber diet in diverticulosis, so that diverticulosis and diverticulitis, to make sure that the fecal matter moves over and through the sigmoid colon and doesn't fill up the diverticular pouches. So telling the patient what are those things that sometimes get lodged in the diverticula and the fecal matter gets trapped in there. Foods with indigestible roughage, seeds, popcorn, nuts, etc. All right, let's look at intestinal obstructions now. Intestinal obstructions can happen in either the small bowel or the large bowel, and I guess there could be situations when it can happen in both. The most common type of intestinal obstruction is going to be your small bowel or your small intestine obstruction. In fact, as you can see from the slide, 85% of all intestinal obstructions are small bowel obstructions. And what is the most common cause of a small bowel obstruction? That would be adhesions, what you see right here. Adhesions is a fancy term for scarring or scar tissue. If it is a large bowel obstruction, the most common cause of large bowel obstructions are going to be tumors or masses. So also remember that We can have different types of mechanical obstructions other than those caused by adhesions or tumors. Two that I want you to know and to remember are volvulus and intussusception. A volvulus is what you see here, and a volvulus is where the bowel twists over or twists around on itself. It constricts itself by twisting around. It can happen in small bowel as well as it can happen in large bowel. So you can imagine with that twisting around, not only is fecal matter not going through there, but maybe an even greater potential complication is that it's cutting off its own blood supply, and you might end up having an ischemic bowel or a dead gut. The other is intussusception, which is a telescoping in of the bowel into each other, onto itself. And I think in pediatrics you learn about that, where it's like a telescope or for a pirate, and they click, 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 and they extend it to its full length, and then they look at the other ship coming, and then they want to put it back to the smaller size, and so they push it back in on itself, click, 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 click. And that's what's happening as the bowel is pushing back and tucking itself in on itself. And so that is called an intussusception, which also obviously as the bowel tucks back in on itself, it's going to cause an obstruction and prevent the fecal matter from progressing through the bowel. So with a small bowel obstruction, what can you anticipate seeing relative to your assessment on the patient? Vomiting, and that makes sense. Why not diarrhea? Because it's a small bowel. It's higher up in the GI system. So kind of picture that image early on where we were talking about anatomy and physiology. You have your esophagus, you have your stomach, and then you have your small intestine. So with the small intestine, if it becomes obstructed, the gases, the fluid, the foods are going to build up proximal to that obstruction, and they're going to back up. And eventually, interestingly enough, the peristalsis will reverse itself. So when the peristalsis reverses itself because of the obstruction, it's going to then propel the food back upwards, where it eventually is going to get back to the stomach, and where it's going to distend and fill the stomach, and it's going to cause vomiting. Small bowel obstruction is important to auscultate the abdomen for bowel sounds, and you're going to see and hear, excuse me, not see, but hear high-pitched tinkling sounds early on. Very, very unique if you've heard them. Very different than the gurgles we're used to hearing. And literally, high-pitched, and then it sounds like tinkling. And then it's going to progress from that high-pitched tinkling sounds to absent bowel sounds. And that's when it's becoming a little more serious, a little more ominous. Cramping and abdominal pain, fluid and electrolyte loss is going to happen from your vomiting. And we'll talk about metabolic alkalosis and acidosis and respiratory. So let's not worry about that for right now. Large bowel obstructions, we're not going to see vomiting because it's a lot lower on, but what we'll see is a lack of passage of stool. So we'll see constipation, abdominal pain. You'll see abdominal distension on that patient. Bowel sounds also important. Initially with the obstruction, you're going to hear those same high-pitched tinkling sounds, but opposed to them becoming absent, like it happens with small bowel obstructions, it's going to progress into what we call rushes and gurgles, almost sounding like a washing machine. Okay, we're now moving into the final topic area for GI disorders, still in the lower GI, where we'll finish up. And we're talking about colorectal cancer. Colorectal cancer continues to be a major healthcare issue. It's something that we have to screen for beginning with age 50. Let's talk a little bit about what it is and what it isn't. When you have a colonoscopy done, what the doctor is looking for are these polyps right here. So if you can, let me just shade them a little bit. So this right here is an example of a polyp. It kind of looks like a uvula, doesn't it? The polyps are not cancerous. So that's important. And for a patient education, they're not cancerous, but they can become cancerous. And so what we want to do is identify them at this stage when they're still polyps, and they want to excise and they want to remove that polyp. Because it does have the potential to become a malignancy. So if your patient wakes up and they're all sad and disappointed because they tell you they have colorectal cancer, and you say, what makes you say that? And because the doctor found 2 polyps. No, polyps are not cancerous. They can't develop into cancer. That's why we want to remove them before that happens. They're still going to send them off for biopsy, but they're rarely cancer. They're typically in the precancerous type of tissue, or tissues that can become malignant. So this is a good slide to know. What are the risk factors for colorectal cancer? Diets that are high in red and processed meat. Obesity, there it is again. Obesity is a risk factor for many, many different types of cancers. Sedentary lifestyle, inactivity, as you get older, over the age of 50. And that's why at 50 and older is when it's recommended that we have a colonoscopy to look for polyps. There is a genetic predisposition for colorectal cancer. The other risk factors, high alcohol intake and smoking, and there is nothing good about smoking, and I am going to get on my high horse. I prepare you right now when we get to the respiratory lecture, and we'll talk about how to eradicate smoking from society. All right, so diagnostic tests for determining a patient to have colorectal cancer. There's the barium enema again. Remember, barium swallow, upper GI, barium enema, lower GI. Endoscopic, upper GI is going to be your EGD, ERCP. Lower GI, sigmoidoscopy and colonoscopy. Colorectal cancer typically will start obviously in the rectal area, but also in the sigmoid colon. And we'll talk now about this carcinoembryonic antigen. Way back when we said in diagnostic studies that CEA was a biomarker for colorectal cancer. So it's a blood test, and normally you are not going to find carcinoembryonic antigen in the blood, and CEA is a clear indicator when it's found on a blood test that the patient does have colorectal cancer. Clinical manifestations for colorectal cancer: change in bowel habits, passage of blood in the stool, pain, weight loss, abdominal mass. Probably the most important ones are this change in bowel habits and passage of blood in the stool. I have had a friend, still a friend, but he was diagnosed with colorectal cancer when he was in his late 40s. I believe he was 48 years old. The only thing he had was a change in his bowel habits. He was your typical type A. He kept himself in great shape. He watched what he ate, but was having problems with his normal bowel pattern. So he went to the doctor. The doctor said, well, you might have picked up some sort of a parasite or bug from when you were traveling, but you know what, you're close enough to the age of 50, let's go ahead and get that colonoscopy. So he underwent a colonoscopy, even though he was 48 years old, and he had stage 4 colorectal cancer with 14 masses in his liver. He underwent surgery to remove 2/3 of his liver, chemo, radiation, just miserable, and passed away a little less than 2 years after his diagnosis. Again, what was the only clinical manifestation? He had it otherwise healthy and wealthy and wise and active, and but he had a change in his bowel habits. So sometimes there is not a choice with colorectal cancer other than cutting out that piece of diseased large bowel. And we still have to evacuate the fecal matter. So what's remaining of the colon will be brought to the outside of the abdominal wall, and a stoma will be created. Remember, a stoma should be pink to bright red, moist and shiny, and we always want to provide that good skin barrier around it. We want to check for skin integrity breakdown issues with stoma care, and we always want to make sure that we empty the bag when it is 1/3 full. This pictorial just tells you that depending upon where the colostomy is, whether the ascending, transverse, or descending, the closer it gets to the descending colon, the more water is absorbed and the more formed the stool will be. So if you have a colostomy, in the descending colon here, it's probably going to be formed and look pretty much like a normal stool would look. Again, emptying it when it is 1/3 full. Okay, irrigation is something that is done only on colostomies. It's to help promote evacuation of the stool from the colostomy. I think you saw a video on that. And just don't get that confused again with the one-way nipple valve that we saw on the coccyliostomy as a surgical procedure for ulcerative colitis. That was a one-way nipple valve. The patient self-catheterized themselves to remove the stool. That is not what irrigation is. And again, irrigation only takes place in the colon, not in ileostomy. Okay, we're really not going to cover it. Yes, there are surgical treatments for colorectal cancer, but you're going to have a full module later in Med-Surg that's going to talk about oncology. So I'm not going to go into it at this point. And for health promotion, and the other thing you could um, substitute promotion for education. So patient education is important. Encouraging our patients to begin having colonoscopies at age 50. If the patient has a polyp, they will have to have the next colonoscopy in 5 years. If the patient has no polyps, the next colonoscopy will be in 10 years. So one of the manifestations, remember, was blood passage in the stool. So the doctor, if in high-risk patients or multiple polyps, they may ask the patient to undergo maybe fecal occult stool samples on a yearly basis. Lifestyle changes to help to reduce the risk for developing colorectal cancer. Stop smoking. You should do that anyway. Healthy body weight. Obesity, remember, is killing Americans. Reduce the amount of red meat. There it is again. Red meat and processed meat, and consume alcohol, but only in moderation. Well, here's the final slide, and I'll close with a thought. If the purpose for learning is just to score well on a test, well, you've lost sight of the real reason for learning. And I'll say that's the same and even more true with nursing. If your purpose for learning for nursing is just to pass the next test, you've lost sight. The reason that we're encouraging you to learn and to really know and embrace this information is so that you can safely, compassionately, and effectively care for the patients in your charge. I've really enjoyed the presenting to you, and look forward to watching you succeed in becoming a registered nurse.